Hello and welcome. This has been obviously a very, very tough time for the entire medical profession in dealing with the rising number of COVID-19 cases and the outcomes. The number of COVID-19 cases specifically, if you go by the data, is now coming down across most parts of India, but the number of deaths are still high and rising, also because we have a problem with registering or counting of those deaths. Now, that's a slightly different issue. Another issue that many people are faced with, particularly in cities like Delhi, Bangalore, Calcutta, and maybe even cities like Mumbai, is the gap between the amount of healthcare services and facilities available and the sheer demand. We have to remember that demand usually does not come from only within cities, but from outside cities, as many areas outside of the big cities do not have the same levels of secondary or tertiary care. So the larger question is, how are hospitals working at times like this? How are they managing the sheer pressure that they're facing, both on physical and, of course, medical infrastructure? When I say medical, I mean the people who are at the front lines, that's doctors and nurses, given the fact that they themselves face threats from this highly infectious version of COVID-19 that we are seeing today in the second wave. And finally, what are the lessons that we could potentially learn from this as we go into the third wave, if God forbid, it is even half as bad as what we are facing today? So to discuss this and answer some of these questions, I'm now happy to be joined by Dr. Nandakumar Jairam, who is the advisor to the Manipal Group. Dr. Nandakumar Jairam was earlier Chairman, CEO, and Group Medical Director for the Columbia Asia Hospitals in India, which is now folded into Manipal as of late last year. Dr. Jairam was also the chairman of the National Accreditation Board for the Hospitals and Healthcare Providers Group under the auspices of the Quality Control of India, and past chairman of the Health Services Committee of FICCI. He was also a member of the Health Insurance Forum of IRDA and FICCI. He was also a consultant colorectal and general surgery consultant for colorectal and general surgery at Columbia Asia. And he's trained in colorectal and minimally invasive surgery, and has spent time in the United Kingdom, the United States of India, and has studied earlier in Bangalore at the Bangalore Medical College. Dr. Jairam, thank you very much for joining me. So let me start off with a fairly simple question. Now, Columbia Asia, which until recently you were chairman of, has 11 hospitals across Mumbai, Gurgaon near Delhi, Kolkata, and many other places. So, sorry, not Mumbai, Bangalore, Kolkata, Gurgaon, and so on. So tell us about, from a pure facilities infrastructure point of view, what you have been seeing, particularly in the last 1 year, and how have you been coping?
Right. So we have principally our presence in Bangalore, where we have 5 hospitals. And just to correct what you said, we have another hospital in Pune, which is the only hospital in Maharashtra. Well, to tell you about COVID, it caught us by surprise last year. We were unprepared, and we had a disease that was not known to us, a disease that was probably new to mankind, and nowhere in the globe did we have protocols for treatment. So the initial part was a lot of kind of discussions and managing it, understanding the kind of virus it is, and hoping that the protocols that we have set, and of course with the help of the Government of India and the ICMR, were appropriate for the patients. Let me classify what we did into 3 buckets. Firstly, the non-medical infrastructure. What was very clear was that the circulating air in the hospital had to be completely separated for COVID patients compared to non-COVID patients. And we had to have a green channel for the movement of patients, which did not allow contamination of those who were not infected. This is one of many changes that we had to do in order that we took care of this pandemic. Then there was the issue of medical and nursing personnel who last year were not immunized and therefore highly susceptible, and the lack of PPEs and other protective equipment, and an understanding of how these should be worn, how one has to manage, and so on and so forth. This set us thinking, and not only that, we had to quickly improvise and manage earlier with what was not available, and later, unfortunately so, with large numbers that were quickly manufactured in India, and I compliment those who had done this substantially. The third and significant was to handle the morale of the medical staff, which, and not just the medical staff, actually every single person who was in the hospital, from fear, and also to push them and egg them on to continue to work. The number of people who had COVID at that time amongst the hospital staff was quite high, and we had to manage them as well. But the situation's completely different this year, and perhaps I will talk about it as we continue our discussions. So to say, one was the psychological requirements of the staff that we had to handle. Secondly was the medical protocol. And the third was the infrastructure that we had to quickly address last year, because the enemy, unknown, unseen, had struck with swiftness and severity.
Right. So tell us, about, Dr. Jairam, about what the last month, which is April 2021, has been like, particularly in terms of the kind of, and not even just last month, even the month of May, which we're in right now, in terms of the sheer demand for beds and what you have been able to manage.
Well, if last year was difficult, this year was multiples more difficult in terms of managing beds. Yes, the situation was very different because now, over the year, two important things happened. Firstly, globally, clear protocols came into being. So the patients could be treated with better protocols, better understanding of the disease and the way it manifests and so on. And therefore, standard of care became much more clear, and it was easy to follow this at all levels, whether it was primary care, in the ICU, or outside of it. The second was the fact that frontline workers, and particularly the hospital staff, were immunized. And therefore, the risk of infection and the number of infections, in all fairness, has been significantly less this year compared to the last. However, the tsunami that hit us in terms of requiring beds was something unimaginable. Of course, we are not over the curve yet, but I believe that we've hit the top and we are on the way down, and hopefully it will stay that way. But several things had to be handled. Firstly, there were patients who did not need to be admitted, who sought hospital care, who pleaded to be admitted, and who had to be kind of spoken to and sent to COVID care centers, which came up quickly. The second was to rapidly increase the number of beds available. Simply stated, the volume of people walking into the emergency room was so huge that we needed to do and help mankind. I must, and very frankly, admit, and I'm sure I speak for the entire healthcare fraternity here, that the demand and supply was inadequate. And there were heart-rending situations where we had to see people wait and suffer for want of ventilator and oxygen beds. Today, I believe the oxygen bed issue is much better, but the ventilator bed issue still persists because there are sick patients for more than 2 weeks, and until they get better, this situation is going to continue. We also had to work with very, very restricted staff numbers. You must understand, for example, a hospital that normally has 75 inpatients had to manage and accommodate 115, which was a stupendous task, with the same kind of manpower that we had before, because you can't produce nurses and doctors from thin air. They are in short supply. However, my compliments to the entire medical fraternity and nursing fraternity. The way they have stood up tells me that there is hope for the future of mankind. They are indeed the angels of today.
Right. Dr. Jairam, when you said 75 patients going up to 115, is this one hospital that you're specifically referring to? And is this the proportion that you would have seen across your hospitals in most parts of the country?
Yes and no. The demand in certain cities was very high. In our hospital in Gurgaon, it was very high. In all our hospitals in Bangalore, it was huge. It was also high in Pune, definitely. But I don't believe that the pressure was as much in our Calcutta hospital, or perhaps we are going to see that in the coming weeks. But the maximum impact, because of our larger presence, was in the city of Bangalore.
Right. Now, tell us about how you are or were distributing infrastructure. So your infrastructure is limited. I mean, of course, now we are seeing the arrival of concentrators and more liquid oxygen on cylinders and so on. But at the point that you were at a peak, how were you allocating resources, and how is that different? And I'm sure it is different from the way it would have been, let's say, a year ago or in some other such crisis situation.
Yes, so we did very many innovative things. For example, I just have to deviate here to say that the way in which our hospitals are planned, our single rooms are very large. It can easily accommodate 2 beds, and there are multi-bedded rooms where additional beds could be put in. So simply, what we did was to increase the bed capacity. There's another thing, and this is fortunately so, that some of our hospitals were still not fully occupied. We had idle space, which we quickly ramped up. And of course, we converted single rooms into double rooms, which have reduced the privacy, no doubt. But let's look at it fairly. If between saving lives and giving privacy, you have to choose, the choice is very easy. So that is what we did. Now, there are other things that I have to really say that I am thankful for. When we started our first hospital in Bangalore, we decided that every single bed will have an oxygen portal. We also invested in liquid oxygen in almost all our hospitals. This paid off very richly. We were fortunate in that we hardly had a serious issue of oxygen in our Bangalore hospitals. We did have an issue in our Gurgaon hospitals, but by and large, it was not as bad as other of my healthcare fraternity have suffered during this period. And I must say that the lessons learned will definitely stand in good stead for the coming months and years.
Right. And what are the other takeaways, Dr. Jairam, if so, in terms of the way you were achieving maybe greater efficiency with existing machines and manpower, which again, like I said, or like I posed earlier in a question, could come into use if we were to face another onslaught like this?
Yes, I think, there are several lessons. Firstly, I know that, a lot of finger pointing is going on as to why this wave was not kind of anticipated and so on and so forth. But let's be honest. I believe that many of us, as human beings, kind of relaxed as the numbers of the first wave came down. We did not anticipate the second wave, the ferociousness with which it hit us, and certainly we did not anticipate that we would be faced with a situation which was worse than what it was in the first wave. There's another thing that we are very clear about. That is the pattern of disease and the kind of people who are affected is not going to be the same. In the initial wave, elderly people were the biggest sufferers. The youngsters were relatively spared, and most of them had very mild illness. This time, it was not so. There were others who were much younger who suffered fairly severely, and unfortunate deaths of younger breadwinners and so on and so forth has really been a very tragic instance this time. Now, what it tells us is as follows. A, you cannot sit back. You have to build idle capacity. You have to be able to open such idle capacities at short notice. You'll have to be prepared for a different kind of disease in the coming months, and you'll have to vaccinate. So every hospital infrastructure and every available opportunity must be taken to achieve each of the mentioned, because that is the way of the future. For example, now, in among social initiatives, which I am also a part of, there is an attempt to build modular ICU beds in government hospitals to increase capacity rapidly. Now, while we do that, it is important that we put in ventilators that work for adults and children, because all of us are being told, and we don't know, but this is what science tells us, that the next wave is likely to affect children. So, if the infrastructure that you prepare is not enough to take care of the population that is going to be affected, then we are in trouble. So, if I can put my priorities, I would say do not stop creating capacity, even if it is likely to stay idle for some time. Create the correct kind of capacity based on the evidence that is available to you. Create manpower, very much like the Home Guard force, which is trained in, even if they are not nurses, they could be, other things. They could be non-allopathic doctors, they could be physiotherapists, they could be others who can pitch in when the time comes. But their
Right.
training must carry on during this period. And of
Right.
course, vaccinate.
Right. Two questions, doctor. So one is, you talked about children. If you could maybe throw a little light on why you say this based on your understanding. I know that you may not be specifically focused on pediatrics. The second part is, we are seeing also, and some states like Rajasthan has declared it, black fungus as an epidemic in itself under a pandemic. So now this is something which perhaps was not anticipated, though black fungus was seen even in wave 1. So would hospitals also need to be prepared for outcomes like this, wherein maybe patients have got cured of COVID, but they then face symptoms like black fungus, which are deadly in themselves?
Yes, actually, I have not mentioned one important fact, and that is the need to follow standard of care. Let's be honest. I mean, amongst the doctor fraternity in this country, there are people who follow what is advised as evidence based, meaning there's a certain prescription that has to be followed, and you follow it to the T, and then you're in evidence base. But if you do not, and you use certain drugs indiscriminately, and in this case it is steroids, then you land with this issue. And mucormycosis or black fungus, as we know, is an unfortunate sequence of COVID, which has been probably overtreated with one drug, and that is steroids. In the presence, of course, of reduced immunity, fungus will definitely be there. Now, we then go back to say every single doctor must be spoken to, advised to follow protocols and not deviate from it for any reason. Yes, the evidence points towards children being more vulnerable in the coming wave. One of the strong reasons for that is that they are the least vaccinated. Why least? I mean, they're not vaccinated. Till now, in this country and perhaps across the globe, children have hardly been given vaccines because we don't know its safety in children. So there is a need for us to develop a vaccine, or perhaps support the development of a vaccine that will work with efficiency amongst children and quickly vaccinate that category as well. Because, the children are very likely to rapidly spread the condition. Imagine if a school is open and there's one child who's infected, the speed at which the virus can spread to the others is huge. So, simply stated, they are the most vulnerable section of society today globally.
Okay. Slightly larger question, Dr. Jairam. What is it that we can do from a policy intervention, if so, to address this? I mean, you talked about both the areas. One is children as a potential future area of concern, and the other outcomes of over prescription or steroids specifically. and maybe doctors not following evidence-based medicine approaches. What is it that we can do from a more macro policy point of view?
Well, there are certain things that can happen, and I believe that the best method is to repetitively convey to the community that treats these patients the protocols that need to be followed and the problems of not doing so. No doctor, in his rightful sense, would prescribe a drug if he knows that it's likely to cause mucormycosis. So it is by repetitive information dispersal, which is so easy today with social media, with WhatsApp, and so on. So, bodies like the National Medical Council, the governments of various states, should blast the protocol on WhatsApp to all the doctors to ensure that they are in knowledge. The second thing that we have to do is to propagate the importance and safety of the vaccine much more than what we've done. I mean, let's accept it. I think we did a good job. We did have leaders themselves demonstrating that they were being vaccinated as proof that they were accepting it. But we need to do more. We need to get others. We need to get cricketers. We need to get film stars and various others to kind of propagate this amongst people and say, it's safe, please vaccinate yourself. This vaccine is not made by a political party. This vaccine is made for you by the country.
Right. Doctor, you're a colorectal surgeon. I don't know if there's a COVID connection at all here, but in general, people who suffer and have suffered from other disease conditions, how have they managed in this period, particularly speaking from your hospital's point of view and their relationships with patients? And how do you think that's going to play out, given that COVID is going to be the major part of, or is going to consume most medical and hospital administration resources in coming months, if not years?
Right. Before that, let me give you a small disclaimer. It's been quite some years since I stopped practicing, and I've been doing only administration for quite some time. But however, I can answer your question fairly accurately. Basically, what I would say is that, the non-COVID work has come down in volume automatically. People have stopped going to hospitals for fear of contracting COVID. But you must understand that there are several categories of people with non-COVID conditions. You have those who can wait. I'm sure all of us know of a condition called a hernia, which is quite safe by and large, unless it's complicated. And you can delay the surgery for a hernia by several months without any worries. So many of these conditions have automatically kind of taken the back burner. There are others who have cancers, for example. It's not an emergency, but the longer you wait to get treated, the less likely are you to be cured. So in such a situation, between the doctor and the patient, a decision to take a risk or otherwise is taken and patients are taken care of. The third category is emergency, where whatever it may be, it could be an intestine that is ruptured, it could be an ulcer that is ruptured, it could be bleeding. There you have no choice. Just take the patient in and treat. In all fairness, I would say that compared to the first wave, where elective work came down tremendously, in the second wave, there is a certain amount of confidence amongst people, and they do seek attention for the latter two that I mentioned.
Right. And last question, Dr. Jairam, your advice to citizens, patients, potential patients on when to approach a hospital, when not to approach a hospital, essentially how to live life in the context of the medical system in coming months and maybe years.
Right. So I'll classify that into COVID-like and non-COVID. If you have COVID-like symptoms, then I would suggest that the first thing that you would do is what is already known and well advocated. Mask yourself, isolate yourself to wherever you are, call a helpline, or seek teleconsults with the doctor follow their advice. If you have difficulty in breathing, then you need to go into a center. And that is one symptom that you should be aware of, which tells you that you are at risk. It is this symptom that should prompt you to seek physical medical attention in an appropriate place. If you have a non-COVID condition, please address it as far as possible through a teleconsultation. Because teleconsults are becoming much more popular, doctors are much more capable of understanding over a phone call or a video what your problem is, and then decide whether you need to go to a hospital or not. But if you have certain symptoms which are obviously an emergency, chest pain, all of us know that could mean a heart attack. Do not wait. Wear a mask, preferably an N95, reach a hospital, and I'm sure you'll be taken care of. It's difficult sometimes to predict which is emergency, which is not, but then that's as far as we can go in terms of advice to the layman.
Right. Dr. Nandakumar Jairam, thank you very much. Pleasure speaking to you, and thank you for all your very important insights and thoughts. Thank you very much, and hope to speak to you again.
It's been a pleasure, and yes, I will be more than happy to talk to you again.
Thank you.